Good morning, everyone. Thank you for joining us. Today we have the M-TAC first episode psychosis series, empowering mobile crisis teams to recognize and respond to people experiencing FEP. This is session 3. We're going to focus on follow-up check-ins, connection to ongoing services, and today we're going to talk about coordinated specialty care, also known as CSC. Today we have our presenters back from the EpiCal team. We're very excited to have Dr. Pierce and Dr. Hayden Lewis with us today. And I am Danielle Ragib. I am with the M-TAC Training and Technical Assistance team. And I will hand it off to Dr. Pierce and Dr. Lewis quickly to introduce yourselves.
Good morning. Thank you so much for having us. Happy to be here with everybody today. I'm Dr. Katie Pierce. I work with our EpiCal team. I mostly help with outreach, so helping different clinics connect with their communities. So that's really my area of interest. And then I'll pass it off to Dr. Hayden Lewis to introduce herself as well.
Hi everyone, I'm happy to be here. I'm working as an external consultant with the EpiCal team, and I bring a whole bunch of experience in community-based coordinated specialty care, as well as a specialty focus on working and partnering with rural and frontier communities. So I'm really happy to be here today and share some knowledge and learn something, and hope to enhance the wonderful work you're already doing in your own communities. Thanks for allowing me to be here.
Thank you both, and we're happy to have you here. Excited to learn from you both today. All right, just a couple things to get through before we get started. This presentation was prepared for the Medi-Cal Mobile Crisis Training and Technical Assistance Center, also known as M-TAC, which is funded by the California Department of Healthcare Services, administered by the Center for Applied Research Solutions, in collaboration with Advocates for Human Potential. That was a lot. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or the positions of DHCS, CARS, AHP, or the M-TAC project. All material appearing in this presentation, except for anything that is copyrighted and is in the public domain, may be reproduced or copied without permission from DHCS or its authors. Citation of the source is appreciated. Please do not reproduce this training for a fee without specific written authorization from the M-TAC project. Today's training will be recorded and posted later on the website for anyone who would like to reference back or who didn't get to attend live today. All right, this is session 3 of the M-TAC FEP series. Today we're discussing follow-up check-ins, connection to ongoing services, and coordinated specialty care. We just like to do a quick land acknowledgement. So we acknowledge that this virtual training is taking place throughout the unceded territory of California, home to nearly 200 tribal nations. As we begin this event, we acknowledge and honor the original inhabitants of our various regions. A land acknowledgement is a critical step towards working with Native communities to secure meaningful partnership and inclusion in the stewardship and protection of their cultural resources and homelands. Let's please take a moment to honor these ancestral grounds that we are collectively gathered upon and support the resilience and strength that all Indigenous people have shown worldwide. And just to speak a little bit in regard to the importance of today's training is presented in partnership with the California Collaborative Statewide Early Psychosis Program Evaluation, also known as EpiCal. They're a work group, and we are so excited to bring their expertise to the field of mobile crisis response. Mobile crisis teams work directly in the community and come across a never-ending spectrum of different types of crises. Having this foundational knowledge of psychosis is crucial in delivering safe and effective mobile crisis services to the community that reduces the use of restrictive interventions. Without proper knowledge and skills for working with individuals experiencing psychosis, we can potentially cause harm to the individual and the family in crisis and the community at large. And so the importance of today's training is that, we may not all, as mobile crisis team members, we may not be familiar with coordinated specialty care or the CSC model, and what the components are, how accessible, where do we access it, and what's the eligibility criteria for an individual to access this program or model. We were going to learn a little bit more about how the CSC model may not be the right fit for everyone and why. And again, today's training is intended to empower mobile crisis teams to feel better equipped for coordinating care and providing ongoing support and services to individuals and families experiencing FEP across the multiple levels and layers of systems of care. Today's training is recovery oriented, trauma informed, and offers person-centered approaches. Again, just a recap of the series. So we have 4 trainings. This is the third of the 4. And you can see the first 2 that happened, one in January, one in February. The next training will be at the end of April. And each training is followed by a community of practice discussion. I'm going to hand it off to Dr. Pierce to share a little bit about the learning objectives for today.
Thank you. Before I hop into the learning objectives, I do want to note that you're going to see a lot of text on the slides today. You'll probably notice as we go through that we won't read everything that's on every individual slide, but wanted to make sure that that information was there for everyone for you to look back at and reference if you need to. Some of the things we're hoping to cover in our presentation today. First, really just describing appropriate follow-up check-ins after a mobile crisis encounter, being able to learn a little bit about coordinated specialty care and the person-centered approach that it takes, and if that approach might be a good fit for an individual who's experiencing crisis. And then understanding some of the strategies for really coordinating that care. So our goal really is to talk about all of the components, what they look like, what different programs might have, because this we'll talk about quite a lot later. It differs a lot based on the county that you're in, and just getting everyone to a spot where they feel comfortable talking through different options with individuals.
Thank you, Dr. Pierce. And just to recap, we've had this information in all the trainings thus far, and we just really want to have, continue to provide this information as a key reminder that the primary goal for mobile crisis teams, whether you're working with someone who is experiencing psychosis or not, is that we provide brief intervention that supports relief and de-escalation in the moment, working from the least restrictive lens or means as possible. We want to meet the individuals where they're at, and we want to support them based on where they're at. We want to build trust. We want to listen. We want to engage and partner with those in need, including their family members when appropriate or their natural supports. We always want to ensure their safety. We want to understand everyone's individual and unique needs and preferences, and we want to honor them through their voice and choice. We want to instill hope for the future, and we want to provide follow-up care and link individuals and families to the most appropriate services that support their ongoing care.
Really jumping off of what Danielle was just saying too, just a reminder that as responders, our goal really is to get individuals back to what matters to them. So it's not just about controlling symptoms, it's really more about focusing on wellness as that individual defines wellness in their own lives. And really, whenever we can, encouraging natural supports to help folks meet their goals.
Thank you, Dr. Pierce. And just to recap a little bit on the follow-up and continuation of care and what that looks like in regards to a mobile crisis encounter. I know a lot of you are familiar that with the requirement that a follow-up check-in is required within 72 hours of that initial mobile crisis response. And the purpose of that follow-up is really to support, continued support of the crisis, right? And the resolution of that crisis as appropriate and effective as possible. And so we really, when we connect back with the individual or their family members or caregivers, support systems, we want to make sure that we're referencing their safety plan and asking questions like, is it still working? Is it still relevant? Are there additional things that are happening or going on that we need to address? Are there additional referrals or resources that need to be made? And we want to provide that support as needed, because in 72 hours, things could change. And I'm sure you're all familiar with that. If we provided a referral and we provided some sort of linkage or support during that actual mobile crisis response, as part of our follow-up, we should be checking in on it, right? Hey, how did that appointment go? Did you get the phone call back, or did you make the phone call? And if support is needed to schedule or make sure that there are no barriers like transportation or language accommodations that are needed to make sure that support or that access to that support is is successful, we want to make sure we're providing as much information and follow-up and care as we can. And reminders are really helpful. I need reminders, and I'm when even when I'm not in crisis, I need reminders. If it's not on my calendar, it's not happening. So um, we all need a little bit of support here and there. And some best practices for follow-up after a mobile crisis encounter. And these are things that, we all know. We've talked about them a bunch over the past year. And so individuals have a right to confidentiality and privacy. And so mobile crisis teams, we really need to make sure that we're explicitly getting permission to share discussions with families or other natural supports on scene, or even when we're making referrals and sharing information, right? There are things and processes we need to follow and make sure that we're respecting that person's privacy and that they're allowing and giving us approval to share information. Individuals in crisis may also prefer not to integrate their families into their plans for follow-up care, and we need to honor that. We can always ask and encourage whether family engagement is safe and appropriate, or if if the family members or caregivers are gonna be supportive as part of their follow-up, and make sure that we honor their voice and choice. When we bring family members into the conversation, make sure to gauge how the individual is feeling about that engagement, and if what they are willing to share, if they are. If the family is continuously at odds and unable to engage in a meaningful, respectful conversation, it may not be it may not be the most appropriate time to engage the family. So we really have to make those decisions when we're out in the field, and also make decisions collaboratively with the individuals and caregivers. And so we want to know, like, have we been helpful, right? Ask all the clarifying questions you need to, and actively listen and reflect so that they can see that you are listening to them and you're understanding what they're telling you. Be ready to repeat, confirm information, be concise, concise, calm, and respectful. Again, permission is important, and confidentiality and privacy are key. And so, with all of those things in place, we can ensure effective, healthy, safe follow-up for all. All right, some of you may remember Max from the previous trainings. We're going to revisit Max's crisis. So we are with Max and his father, Robert, and I'm going to hand it back to Dr. Pierce and Dr. Hayden Lewis to help us revisit the situation.
Great, thank you. So as a reminder, Max is a cisgender male identifying individual. He's 25 years old, identifies as half white, half Mexican, and English is his preferred language. As a recap, it was 10 p.m. on a Saturday night, and you were called to an apartment. The caller was a father who spoke English, whose name is Robert, who's very concerned about his adult son's behavior. You spoke to the son, Max, and he stated, "I'm just so scared," like all the time. It started a few months ago. I started noticing cameras in all the stores and all the restaurants, and they're all over this apartment complex. At night, I go out to walk because I'm so worried that I'm being recorded while I'm in my room. I don't know why, but I do not feel safe there, and I can't sleep. My dad just doesn't understand. He gets mad when I ask him about the cameras or what he's putting in my food. He gets mad when I leave the apartment at night. He's worried about me, but won't listen when I explain it, and I get so mad. He thinks I'm using drugs, but I'm not. I'm worried he's going to kick me out, and I'll have no place to go. And I've already missed 2 days of work every week for the past 3 weeks, and I'm also worried that I'm going to lose my job.
And to recap the situation for Robert, who is a cisgender, male identifying 57-year-old who identifies as white. English is his preferred language. Another person talked to the father, and by the way, person, well done on encouraging disclosure and building some trust to even gather this information. So you've already done really well here. Robert said, "He thinks I've put cameras in the apartment to watch him. He thinks I'm putting medications in his food, but I'm not. None of this is true. At night, he leaves the apartment and walks for hours. I assume he's meeting up with friends to get high, but I don't have any evidence. Maybe he has a medical illness like my cousin. When he gets mad, he screams and throws objects. Last week, he stepped up like he was going to hit me, but he didn't. I was so scared. I can't take this anymore."
So, what do we know so far? We're getting very different perspectives from Max and from Robert. From Max's side, for risk, I get really mad at my dad. He's concerns that his housing might be at risk, that his job might be at risk. His concerns, he's feeling scared and unsafe, feeling watched. What makes it a little worse and better? We know that Max feels really angry when he feels like his dad isn't understanding him or listening to him. We know that leaving the house can help because he feels like he's getting away from some of those cameras that might be in his room. He really wants his dad to listen and to help him and be more supportive. And he's also worried that if the police get involved, they might see him as a troublemaker because of the color of his skin.
What do we know so far from Robert's perspective? And backing up one pace, we know that there are different perspectives, and that different perspectives are causing stress and conflict. And from Robert's perspective, different from Max's, that Robert is concerned about Max getting mad and experiences a sense of threat against himself. Robert is concerned about Max wandering at night. That housing situation comes across as unstable for them right now. Robert's concerns, as he understands it from Max's perspective, that there are cameras in the house, but there aren't cameras in the house as far as we know. Robert's also handling Max's concerns about putting medications in foods. Robert's explanation right now is maybe there's possible drug use, or as he said earlier, maybe a medical illness going on. So he's trying to make sense of what's going on here. What makes it better or worse? Robert is wondering, are the drugs helping or making this worse? He doesn't know. Robert wants to talk about household matters without an argument. Robert wants to laugh together. Robert really wants to support Max in saving enough money to move out on his own. Robert's worries are that he's going to lose his son because he lost a cousin 5 years ago in a traffic accident. And this is reminding him of that loss and those concerns. Robert's also concerned that his own home isn't feeling safe for him to be in. So what are some identified supports? What are some supports for Max? The way I want to talk about this a little bit is inkling towards where coordinated specialty care might be a match or not. So some considerations, supports for the son. So getting a link to treatment so that Robert and Max can both feel heard and supported. And the ability to understand what services exist in your community can really help make that link between what's mattering to each person and what's available to help address their concerns and meet their goals. Housing support. So with coordinated specialty care and folks experiencing psychosis, in general, they're going to have a higher risk of unstable housing for a number of reasons, from discrimination to expectations to household conflict that's not mitigated with effective skills. So one of the supports could also be working towards reducing those potential negative consequences if these experiences continue to worsen or escalate or be compounded without additional supports. And that's also really common when people are experiencing psychosis, that the symptoms are confusing and they're new for everyone in early intervention. And that can create conflict and different perspectives and competing demands, which we know threatens housing, employment retention. So this work is really important. Not sure yet, staying curious about is how the role of income is that playing in the family right now. And also employment retention can really help people stay maintaining a sense of involvement in their daily activities, typical activities for their peers, as well as an expectation and responsibility as a household member for many people. Another support to consider, crisis residential. Is that needed right now? Or is that something that might be on the back burner down the road? So really assessing, using the skills and your own experience, what level of crisis and how could we mitigate that, really hoping to keep the young person in their existing housing situation and really protecting those connections to natural supports and family members. We know those are very useful in coordinated specialty care. Safety planning. When Max is angry, expressing this anger towards Robert, what are some resources that they could have? Calling 988, calling mobile crisis again, calling the police, trying to avoid law enforcement whenever possible. And at times, that's a necessary call to make. Also, this notion of giving space. So for people experiencing psychosis, giving space can actually allow them to get the space that they need to make sense of what's going on inside of them, to make sense of their new perceptions of their surroundings and interactions. It may be that some support that you all could offer is helping make agreements how to assess when space is supportive and when space indicates that there's a worsening of experiences or symptoms indicating increased risk. So there's some learning to go on here.
So I'm noticing a response in the chat, right? Some family support, great. So for our next step, I really want to talk about what coordinated specialty care or CSC is. This is our coordinated specialty care model. This is a team-based program that provides a whole variety of different evidence-based services for individuals who have recent onset psychosis, or sometimes also called first episode psychosis or FEP. Our model really focuses on both the service user as well as their support systems, whatever those supports may look like, whether that's family or close relatives, partners. For adults, it really is a conversation about how and who they would like to be involved in care with them. So there's a lot of different things that clinics can offer. So one of the things that I want to really pin down today is a lot of different counties offer slightly different services. A lot of the counties that EpiCal works with are trying to get as close to this full model as possible, but there are challenges when it comes to things like funding or maybe being able to find someone to fill a certain staff role. So it's really important for the community that you live in to be aware of what kind of clinic is in your community and what are the different services that they offer. It can be really good to check in periodically to see if anything has changed. For example, a clinic might have a psychiatric provider and then may lose their provider and then might have to take some steps. And so it can be good to keep up to date on what folks offer. But let's talk about the ideal situation. Ideally for CSC, every week, every team member gets together and talks about the cases and individuals and different needs for their caseloads. So that team includes several different individuals. One's a psychiatric provider for health and medication management. For CSC, we do not require individuals take medications. However, we do have that individual on the team to provide information or other health-based information if needed. We have a clinician, usually trained in cognitive behavioral therapy or CBT for psychosis. We have a supported education and employment specialist. Sometimes this is filled by one individual in both roles or by two different individuals. We have assertive case management, peer and family partners, and then typically we also have clinics who are a little established in their communities going out and doing community outreach and education. So if we're thinking about that situation we just talked about with Max and his father Robert, if they were to come into the CSC model, they might be interested in some of the services that are offered. So for example, they'd be able to talk to a provider to see if medications might be helpful. They'd be able to talk with a clinician who would be able to go through kind of what Max's experience has been thus far and talk about ways to help increase feelings of safety. If Max is concerned about losing his job and concerned about his absence days, he might be interested in talking to someone for that supported employment role to see if there's anything that he can do to make sure that he keeps that job as long as he'd like to have it for. Assertive case management might come into play, especially if Max is worried about housing. And that can be a conversation with the case manager, with the father, about what kind of housing situation makes the most sense for the family. And then peer and family partners. So many clinics offer both a peer who themselves who has experienced mental health difficulties, or a family partner, so someone who has supported a loved one in their recovery of psychosis. So there may be individuals who are there that can really talk with Max and with Robert separately about the things that they're experiencing to provide that peer support. But again, it's really important to check in because each county is so different. Each program differs a little bit to make sure you know which of these components are available for your area. Most CSC programs have really specific requirements for individuals to be eligible for them. This can also differ clinic by clinic. We are trying to work with the state to move to a broader diagnostic understanding for the criteria at this point. But a lot of common things you might hear are we only take individuals within a certain age range, only specific diagnoses, or a certain length of psychosis. For example, some programs might only be able to see individuals if it's within 2 or 3 years of their first episode, but that can differ a bit clinic by clinic. I also really do want to highlight that programs don't necessarily assume that individuals will want to engage in all components of CSC. For example, you might imagine that if you were Max and you came into a program and they said, we offer all these things, we're going to get you set up with a psychiatrist and a clinician, we're going to have you meet with a peer, and we're going to have you meet with a support specialist. It's already a lot of people and it can be really overwhelming. So typically for CSC programs, the goal really is to first, meet with a clinician and talk about what the needs are and be able to kind of ramp up and adjust what the program is providing in order to meet individual needs without just throwing everything at someone all at once, which can be a little bit overwhelming. Typically at the beginning of services, what'll happen is most clinics will do a really comprehensive assessment. So most commonly what this looks like is sitting down with Max, someone like Max, and Robert as well, if Max is willing to have Robert be engaged in that conversation also. And just talking about different experiences that they've had. So for example, when did those experiences where you were feeling like there's cameras watching you, when did that first start? And really getting a good history of that, but then also taking that step back and looking at the rest of these individuals' lives. So not just the psychosis, but what are those other things that are really important to Max and Robert, and can we help support those as well? So really getting in that good assessment so that the team has a sense of what the needs are in the moment. And is CSC the right fit? For CSC models, the goal is really to be person-centered, non-coercive, and culturally informed. Some clinics also have a really trauma-sensitive approach. It's going to be a good fit for some individuals, but not for others. And this really gets back to the needs of that individual. For example, one of the conversations that's had sometimes is, does someone need more intensive services that can be than what can be offered in a coordinated specialty care program? For example, would they really benefit more from a residential program, for example? Being able to have that conversation with the family about what their needs are. Mm, So, as I was mentioning earlier, some clinics that are a little bit more established provide outreach and education to their communities. So, if you have a CSC program that's been around for a long time, let's say similar to the one that's at UC Davis, ACUDAT, for established clinics that offer services that have a really clear pipeline, the goal is to go out into the community, to different mental health providers, to schools, to talk to different community groups and provide information about CSC so that individuals are aware of these services. In some communities, the CSC program is a little bit newer and smaller, and they might still be building up their team and building up that kind of pipeline of services that they offer. And so they might not be at this stage yet. However, as a crisis team member, as individuals that are really embedded in the community, you can really help kind of spread the word about CSC and be able to talk about these services so that folks are aware that they are an option that they can consider. You also might notice, especially in those communities that are already doing this active outreach and education, sometimes you'll come across folks who've already heard of the CSC program and might ask about it as well. So what does CSC look like in California? Right now, the project that Dr. Hayden Lewis and I are a part of is called EpiCal. And so we're really trying to help support CSC clinics get up and running in different communities. And this map, the dark blue and the yellow counties currently have early psychosis specialty services or offer CSC. One of the things that's really exciting to me is how different this map looks compared to even how it looked 5 years ago. There are a lot of counties that are starting to set up different programs, and there's fortunately a lot more options than there used to be. Eligibility is set by each program, and it can really differ from county to county and program to program. So for example, in California, sometimes every county is a bit of an island. So for some clinics, they may only be able to serve individuals who are a resident of the county that that program resides in. Some clinics accepts private insurance and might be able to see individuals with private insurance even if they do not live in that same county. But again, that is something that you have to be aware of for the clinic that's in your community so that you can be able to communicate that information to individuals.
Thanks, Dr. Pierce. So I'm going to talk a little bit about referral considerations. So imagining that you're with Max and Robert, understanding how the teams, as Dr. Pierce was describing, might approach the service user and support person's goals and help. So getting familiar with the model, and then as Dr. Pierce mentioned, the unique configuration of that model in your community. I just can't emphasize that enough in making a referral consideration. Most people will follow up on referrals because what you describe to them as a resource matches their concerns and needs, as well as their hopes. And so if you can just keep that in mind or continue to pat yourself on the back if you're already doing that work, that is really what makes the link. I often think to myself, am I making this make sense to the person I'm talking to? It's just an internal skill to shape my conversation with folks. So really using that reflective and active listening and giving people space and time to respond as well as receive information can be really helpful to help them make informed choices. So the CSC team works really to match those services with people's goals. So the more that you can practice that in the field and in the community with people, the more you're also setting the tone for people that choose into coordinated specialty care programs are going to have a consistent experience with folks in our field. Also knowing that the coordinated specialty care team understands that people's goals and young people's goals change over time. That's developmentally typical, and that's just common for people based on their circumstances, on their needs, and their hopes. And those changes can really impact their desire, but I think a word I prefer is their priorities. What matters most right now to me in the short term or the long term? And these teams are ready to understand and follow along to continue to fit into people's lives. Families and young people might have shared or different goals and needs. This is common on any day, gone anywhere. It remains true when somebody develops symptoms that might be best described as psychosis. So being ready and allowing for differences and modeling that differences could be communicated in your interaction with people, and modeling that can be communicated without stressful conflict. Is really important. People best learn that principle through modeling and practice, so we can contribute and help people make decisions as they make their way into the coordinated specialty care program, which is ready to help everyone involved with permissions in place, meet their needs and address their concerns across similarities and differences. This is a really big component of these programs that stays important throughout the course of the program. These programs end and people go back to their lives, and some of the really powerful and useful takeaway skills are actually navigating similarities and differences, understanding concerns about symptoms, explanations about symptoms, so that people can continue to make decisions when they don't have a team present, with or without a program. So again, modeling low stress, reflective, and active listening helps. It also is an accommodation that seems only fair to people that are already under a lot of stress and already having symptoms or experiences that are taking up a lot of their attention. So when you meet folks, like I was saying, keeping in mind, everyone is already working really hard. One of those other internal things I tell myself, everyone I'm meeting is working really hard already. So really trying to work alongside them to be clear about the description of the services available, making that match, giving people time to make choices. If a person only wants medication and nothing else, I'd say CSC may not be the right fit, or it might be that I want to go back and ask again, is there anything else that matters to you right now that's of concern? Because I find that a lot of people are like, yeah, I really want to keep my job, or I don't want to drop out of school, or I just don't want to argue anymore. Great, CSC could be really helpful. So using that motivational interviewing or curious questions to get some more information to see if this is a match. Practicing transparency is really helpful for everyone. People that are experiencing stress, anxiety, perhaps even symptoms of paranoia or interrupted thoughts, being clear and transparent about what you're doing and what you're offering can be really useful. Again, letting people know that disagreements are okay, welcoming people through modeling to be able to tolerate differences around needs and finding a path through. So having a couple of useful suggestions as a way through that might respond to, let's say, Max and Robert, which we'll get to, I think, again in a minute. Coordinated specialty care is not a perfect solution. It can't resolve all issues from all time, but it can be really helpful to reduce negative consequences on life and life activities if support doesn't get in place. So following a step-by-step approach, these teams offer the opportunities to celebrate successes, reduce concerns, and increase skills that are useful for the here and now, and again, after the programs that they can take away. The role of family members and support persons in check-in, so important. Of course, this needs to be with permission, and these teams can also, if there's some level of interest and permission, these teams can really work with young people or the folks enrolled in their programs in order to discern what could your family be involved with, if not everything. Could we provide some psychoeducation? Would that be okay? Do you want a family member in an appointment with a medical provider? So there are many choices to make. So I always encourage folks to think about, in your role, thinking about these programs aren't working in, I want to say binary options. It's not a yes or no. There's often some gray area to work with, and letting people know that the team is ready to help them work this out. The conversations that focus on shared concerns and shared goals are most effective. So in this situation with Max and Robert, they're both concerned about conflict. They're both concerned about housing. They're both concerned about not being sure about exactly what is going on. Those are actually shared concerns. How they're experiencing them are different. So as much as you can listen for like, oh, they're approaching the concerns differently, but they actually have some shared concerns, and reflecting that back to them, saying you've got some shared concerns. So the team and you might be able to help with some strategies to address those. This last point is so important, and I'm imagining you're already fairly used to doing this, but statements you make that imply an individual is impaired or unable to make decisions are not helpful and can be stigmatizing. This isn't to correct other people and say, no, you're not getting it right, because that's not helpful, but rather modeling and saying, you know, what I know, that Max isn't actually psychotic. Max is a young person having distressing experiences. That's an example of separating the person from what's going on. And again, the more that you model that and can reflect back to the family members, say, Robert, Max may not be, psychotic. You probably wouldn't say that. I would say, Robert, I hear your concern that Max is having some new experiences that are disruptive in the house for you. Am I getting that right? So choosing language as much as you can, and even what I did, transparency, backing up, trying again, demonstrating your humanity is really okay. I think it can actually build a sense of trust and a sense of shared power for some people in some situations. The role of family members and support persons in the check-in. So keeping in mind that cultural differences can impact family comfort with transparent conversations. I've learned this one sometimes the hard way, to much correction that I've needed to do over time, but people want to share different things in front of different family members. That can be culturally driven and values driven. So for example, a parent might not want to share their concerns with a young person present. And vice versa. So one strategy when I was thinking about Max and Robert is to address that with them together. Do you want to talk with me about what's concerning you all together, or would it be more useful for us to talk separately? If the response is, I want us to talk all together, you might suggest, it's usually helpful to have a few agreements when we do that, and provide some suggestions, like taking turns, each person talking, reflecting back what's being said. Separately, you might say, I want to be sure that everyone understands what's going on here so that I can be most helpful to you. If we talk separately, what's going to be the best way for us to come back and talk together again? So negotiating that a bit with family members and young people can be incredibly helpful. Offering to do some brief problem solving to better understand what their needs are and find some additional solutions can be incredibly helpful to alleviate additional stress for the family if unaddressed. These additional stressors, there is no stressor too great or small. What we want to understand is what stresses are bothering them the most. So if what's bothering them the most is that the trash isn't being taken out, that's what bothers them the most. Then let's find a solution. Let's talk about the trash getting taken out. Last one here is a recommendation to call people by their preferred name and gender rather than their role in their family. So rather than mom, dad, or sister, it's Robert or Max, unless you're invited in to call them or use a different word to label them as a person.
Great. And as you're discussing coordinated specialty care as an option, it's really common to get questions, concerns. Of course, there are questions and concerns. People want to make sure that they are doing things that are in line with what their needs and their wants are. Um, it's really important to talk about CSC and to be able to talk through how different parts of that model may fit their needs. And if they have concerns and they're saying, well, I need this and that program doesn't offer it, take that very seriously. CSC isn't the right fit for everyone. The goal really is just to be able to give individuals information so they can make those choices for themselves. So it's kind of that dance between making sure all the information's there. These are some of your concerns. These are some things CSC offers that I think map on well. Making sure you're giving that information without veering over into seeming coercive. Some things that people may experience as they're talking about CSC or really as they're considering any services that they're being presented with is some people might feel really pressured to agree to things that they don't really want to do. And that can really deter people from engaging in services if they feel coerced. And so it's really important to be able to center that it is their choice, how they would like to move forward, what they would like to do. It's also notable that sometimes the individuals that you talk to, or sometimes their supports, have had really negative or harmful interactions with services before. In those cases, it's really important to listen to concerns, to their experiences, to validate that. If it seems appropriate, you can talk about some of the adaptive responses that CSC programs can make and how they can be flexible if that seems appropriate. Uh, Also notable is some programs have different guidelines around engagement and services. So, for example, some coordinated specialty care models might have expectations about how often someone engages in services. And so if you have an individual and they're saying, okay, maybe I'll give CSC a try, knowing enough to say, like, okay, that's great. And encouraging them to talk to their clinicians about, you know, is the expectation to come in once a week? Is the expectation once a month? What kind of engagement would I have to have with this program in order to receive the benefits that I want to receive from it? And being able to have those conversations. Medications, I do want to note again, are just one tool for recovery. Individuals can choose to be on medications or to not take medications. And that decision is something we always really encourage them to make in collaboration with their prescriber so that they can talk about different dosings, or if someone's currently on a medication they don't feel is working well for them for a variety of reasons, to be able to talk to the prescriber about either titrating down safely from that medication or trying something else, trying a different approach. Culturally responsible practices and follow-up care. It's really important to note that young people who've experienced race-based marginalization are often really perceived as having more mental health symptoms than their peers who don't share those identities. What this looks like in practice is oftentimes individuals can really be steered toward interventions that aren't necessary for them or could be overly restrictive. Another thing I like to highlight is that, especially for individuals who are Black or African American, they're much more likely to be diagnosed with psychosis than peers. And so we see that as a group of individuals who's really overdiagnosed. So really just being aware of that. We also have the flip side, which is that for a lot of individuals with Asian American, Native Hawaiian, Pacific Islander identities, that they're often viewed in really the opposite way as having less severe mental health symptoms than their same age peers. And so that can really lead to under-identification and not steering those individuals to services that they could really benefit from. It's important to really develop a routine of checking your own personal biases and assumptions. And it's really great to have colleagues that you trust where you can check each other as well and have these open conversations. really important to seek trainings in cultural humility and to be aware of the different cultures that are represented in your community that you're living in. It's important to welcome diverse explanations for what's going on. It's really interesting. Mental health providers, when you ask individuals to explain where mental health difficulties arise from or what accounts for those experiences, there's a whole wide array of responses and opinions that people give. However, they're more likely to endorse biological explanations of mental health difficulties when those are the primary ones endorsed in their places of work. So just as a reminder to really be open to other perspectives other than biological views of mental health. It's also really important to be able to ask questions about what might be missing. So for example, if you have a family who's really embedded in a religious or spiritual community, asking, is there someone from your community? Is there a leader in your community that you would like us to reach out to, you feel comfortable discussing your concerns with? Is there any way that we can wrap other supports into supporting you? So this is a question, if you could pop a quick answer into the chat. How is the coordinated specialty care model similar or different from your experiences and practices with other places? Similar in that not all resources are the right fit. More person-centered. Yeah, meeting clients where they're at, meeting service users where they're at. Integrating natural supports. I will say, so I've worked in a few different care settings, so general outpatient. I've worked in early psychosis programs. I've worked in psychiatric inpatient programs. One of the things that I personally notice and really appreciate is just the team-based nature of care, where you have so many individuals that you work with that are working toward a common goal for that individual. That's one of the things that I've noticed working in these types of programs. Bonnie's noting in CSC how people often have to coordinate their own care, and that can be really difficult. Yep, very hard to navigate. Thank you.
Just kind of tagging in what you said around that they have that team-based approach and that very similar to mobile crisis teams and that multidisciplinary care. So the teams are multidisciplinary and everyone brings something different. And at times we're looking at, when we're receiving a call for a response and we're looking at, okay, which team member might be best suited to respond to this individual's unique needs at the moment. And that is part of that team-based approach, right? Like we're looking at who is the best person to send to this current person in crisis and how can they best meet their needs and meet them where they're currently at. And so I love that that is the CSC model does the same and that we're talking about that team-based approach and that multidisciplinary care because we know it to be a national best practice.
I think I would add to the flexibility with permission in place on family and support persons' involvement. Really, having worked in these programs, really stands out for me that there aren't requirements, sort of performative requirements by the family to be involved as long as permissions are in place. It can be lots to be psychoeducation, sitting in on a meeting. The young person might change their mind where initially it might be a no, and then with time, as the team works to earn trust and better understand what the young person's concern is, making links back. Could we revisit family involvement? So really keeping the family or support persons in mind throughout the course of care seems incredibly important, and helping everyone gain skills to succeed without an intensive service later on. So those are some of the things that stand out for me. And I was looking at the chat of comments on family involvement, and I know Bonnie is here too. So follow-up practice. The situation revisited. So much has happened in such a short period of time. You all have done incredible work. You've talked with Robert and Max. You've returned to their home for the follow-up check-in. You start the conversation by reviewing the concerns that they discussed during the crisis call. The strategy here, it might be helpful if you're in person to write things down for people. If you're working with an interpreter, be sure it's in the correct language or accessible for ASL. To have things recorded in a way. So you've called with their permission and their trusted family pastor to join you inside the family home. So you've gotten where you can all be together in the same room. These are successes for the family and good work for you all to have done. So each person has agreed to sit in the same room with each other. You've made an agreement not to sit next to each other. Okay, we're in the room, not sitting next to each other. Great. That's also practicing clear trauma-sensitive approach. The people have made choices. We've not coerced them, to the best of our knowledge, to be together. They've chosen into this experience together to talk. The father has shared that his cousin recently entered a substance use treatment center with the financial support of the family. So we're getting a little bit more about where Robert's coming from with his concerns. So that stress might be getting taken off of Max, okay? And now we're turning towards Robert, and Robert gets space and time to be heard. While he is happy his cousin is getting the help he wants and needs, he worries that his son is having the same problem and that time, resources, and emotional capacity seem very depleted. So Robert is now telling us he's not sure how much he can offer, and yet this is Max, he cares. So now we're hearing the family concern and what might be going on and what we in the coordinated specialty care team might address if that's a useful resource. The father wants proof that his son is not using drugs. So that's a concrete, I want to know. So I'm going to hold on to that a little bit. The son has shared that for the past 7 weeks, he's been having interrupted sleep. So I want to think about sleep and is seeing shadows at random times throughout the day. So now I understand that Max has been experiencing new and unusual perceptual changes in the past 7 weeks. So I'm going to imagine person-centered thoughts here that might be stressful and it might be comforting, but it's new. And so that's probably taking Max's attention to sort out. Max has tried to use prayer. So Max has been working on his own behalf and increased visits to the family church to help him feel better, using cultural and faith-based resources to support himself. Okay. Some of the shadows are religious in nature and comforting. Others bother him because they remind him about the cameras and being watched. So it's a both and situation. So some of these experiences are useful, some of them not so useful to Max. He is confused about what is going on, knows about his cousin and his father's worries, so has empathy towards his father, knowing what the family has been going through, and is not sure what else to do. He needs a good night's sleep and someone to sort out what is going on with him and to keep going to school. What's going on? He needs to sleep, needs to keep going to school, and has a lifelong dream. And he's worried he's going to lose these. So what I did, and I would suggest you keep these as a resource, is I went back through and I underlined. I was like, ooh, where would coordinated specialty care maybe come in to be helpful? And if not coordinated specialty care, what are some areas where some help would come in handy? It sure seems like what I got, that this is new and that prayer and visiting the family church is important. So I might think about how would the pastor want to get involved here, validating, Max, you're staying consistent with your plan and with our faith and you're part of our congregation. I don't know, but I might be curious about how to really continue to support that connection. Thinking about where coordinated specialty care or other resources might come in handy for Max. Needs some sleep. So medical providers can help with sleep hygiene. Doesn't require polypharmacy or pharmaceutical interventions. They have strategies around sleep. He's confused about what's going on. So a resource, whether it's coordinated specialty care or not, or the pastor, sure seems like he's trying to make sense, make meaning about what's going on, and probably needs some space and support to do that. He also really matters to him to keep going to school. He has this future goal. I'm thinking additional resources, coordinated specialty care or not, that is going to help keep him on track with his educational needs right now and also future goals. All of those could be served in a coordinated specialty care program, but if that's not a fit, I'm going to want to think about what resources could support that. I'm also keeping in mind that Robert needs some support and deserves some support. So how am I going to work with Robert's need and Max around this issue around drug use? That's something that I'm going to need to sort out. Robert is also additionally concerned about his own resources. So doing some problem solving to match some resources or supports either in the coordinated specialty care or outside of it to help Robert sort through how he's going to gain some more strength and resiliency, and also maybe set some boundaries with his son around substance use. Education for Robert would be good. I'm looking in the chat. What kind of psychoeducation would be supportive to Robert in this situation? If you want to put in chat, I'm curious. Mental health.
Yeah, I think, just he's very, Robert is very concerned about drug use. So providing some information there and the, potential experiences of psychosis, even though we're not necessarily saying that's what's happening, but how that could be potentially something that could be happening versus the drug use.
Thank you. Great. So allowing Robert to have his concerns as valid and needing to be addressed. And there's some more ideas, psychoeducation around validating experiences, moving away from invalidation, maintaining trust and connection. Thank you. So here are some ways that you could respond. Thank you for sharing your concerns with me. These people have disclosed in a vulnerable moment, I'm imagining, their concerns, offering a couple of options. So in my mind, in practice, trauma sensitive would be a couple of options rather than 15 options can be helpful so that people stay in the seat of making their own decisions and we move away from coercion, inadvertent coercion. Wondering how faith and spirituality and religion could be supportive here. We know in the early psychosis research that faith, spirituality, and religion can be incredibly useful, but are often not discussed as part of a care plan and supportive resources. So here is some language you might use, reflecting on what you've heard, checking out concerns, seeing if you got that, pausing, allowing for people to process what's been shared, allowing people to agree or not agree so that you can continue to develop your strategy, making direct connections to the coordinated specialty care team. That's what this response is, making this link. I know of a program. In fact, I know the name of a person in the program. Rather than making a referral to an institution, we're making a connection to a person. That can be incredibly helpful in coordinated specialty care. So the more that you can have someone's name or know who the person is going to talk to on the other end, it's a more personal connection. And most people go to people they know or have names of or have a sense of trust in over large institutions. So that's what this is prompting you all towards to consider. Additional considerations. So we're going deeper now, remembering Max and Robert's concerns, talking about what Isabella in this program can offer: help with employment, help with education, help with finding additional solutions that you're not able to come up with right now. Giving Max, and I would say omission on this slide, Max and Robert some space to listen and a chance to ask questions. I'll note that for the future. So that should say Max and Robert. This is for both of them. Reflecting that this is an tense situation, that we don't want to overpromise what could happen, but finding some short-term solutions where they experience some relief from their stress and some sense of even micro successes can be really useful, and letting them know small successes are going to count here to get us move away from the conflict and the concerns. Small steps are helpful. And then asking permission. Can we get in touch with Isabella right now while I'm here? A lot of people won't cold call on their own behalf until things are really gotten a lot worse to these programs. So that bridge, you can be a bridge to making the call together, can make a tremendous difference in whether your referral succeeds or does not succeed. That is a very big deal here for this group of folks. Again, you can be the bridge in the moment right into the program if folks are choosing to do so.
And Dr. Hayden Lewis, I think what you said too, it's important to highlight that this is different, right? This is different than what they've done before, or they've never accessed this type of resource, or maybe any resources other than their church, things like that. And that can be scary. It can feel like, what is this? Where am I going? Where are you sending me? And we can also like provide information around like, this is just to see if this will work for you. If it doesn't work for you, you don't like it, we can you don't have to go, you don't have to continue with it. And I think it's that it's something different than been what we've been trying to do and to support, and that hasn't necessarily been as helpful. So let's try something different and see if it works. But that affirmation that if you don't like it, that's okay. Application of mobile crisis response. I think everything we've heard today can be applied in your mobile crisis response, your connections and work with the community and individuals and families in crisis. One thing we want to acknowledge is that resources in every community are different and vary. So what's available in one large urban county may not be available in your small rural frontier county. And we acknowledge that. And that makes sometimes, I think even someone in the chat said that we don't have a whole lot of resources. And so oftentimes we're having to get creative with how we can support and what type of connections we can make. And so we want to acknowledge that every community is different, and every accessibility there's not accessibility to a CSC program everywhere. Making connections and knowing your community is important. So what someone said previously, we get creative. We sometimes do have to refer or provide the same resources, but we really try to individualize and meet unique needs as much as possible. It's important to identify what supports are available, what programs are available, including their capacity and participation criteria. Sometimes we identify resources or we identify a place to go, and they don't have availability, or they don't necessarily meet the criteria to participate in the program. So knowing all those things ahead of time will be helpful. If a CSC program is not available in your community, how can you leverage other resources and supports for individuals experiencing FEP? And this might be something you have to take back to your teams and start to strategize and have discussions on. And I think one of the things we realize is a lot of the CSC model is very similar in some of our current approaches and practices. So that's great. It's nothing necessarily new, but it's a great resource for individuals experiencing FEP. Meet the individual and families where they are. That is huge, and that is key, as we've, Dr. Pierce and Dr. Hayden Lewis have shared throughout the training. Not everyone is going to be open to the options you want to provide. And so we want to, validate that and listen to understand what support services might be the best fit, even if we think, I don't know, that's going to work. Voice and choice matters, and we always want to come from that least restrictive lens as much as possible. We do have a couple upcoming resources on the M-TAC website. We are currently working in collaboration with the EpiCal team and other teams to develop a FEP resource map. And so this will be developed and available on the website, and it'll allow counties to actually search by region, county, what available resources in terms of FEP and CSC resources are available in each county. So that is upcoming, and we will share that when it is available and active on the website.
As a broad strokes overview of this process, it's really reconnect, recap, and resource. So step one is really just kind of refreshing that connection that you made with the individuals during that first visit with them, that first meeting. Then recapping, so checking in with each person, sharing your understanding of the first meeting, making sure that that is matching up with what their experiences and understandings were to make sure everyone's on the same page. And then moving on to that resource. What are some of the connections that have been useful, have worked well? Are any different resources really needed? Are there any other things or other strategies that we can implement that would be helpful at this time? Again, there's no one universal approach when working with an individual in crisis. Um, Adapting to every person's experience and what they need in that moment is really what's most critical. And learning to understand and listen to them is going to help really engage and meet them where they're at. So the level of engagement that they want with different services, or the level of engagement they want their supports or family members, community members to have, is really going to differ based on that personal preference. And it's important to center that during this process. Psychosis is unique for everyone, and the recovery process for psychosis is as well. It's important to adjust care to meet an individual's needs. And for coordinated specialty care programs, as I was mentioning earlier, typically that first step is a really comprehensive assessment, and that can be really helpful. Even if an individual receives feedback from the CSC team that, we think other services might actually better fit your needs than what we can offer, it's really great to have that assessment so that they have really personalized and tailored recommendations on what to move to next or what might be helpful to guide people toward.
Here, we are going to just talk a little bit about what we're going to explore in the next training. So the next training will be about practical application of FEP intervention strategies and mobile crisis team integration. So we're going to really look at how do we apply all the things we've learned in the past 3 trainings, and how can we effectively use them out in the field as mobile crisis responders. So we're going to look at applying crisis intervention strategies. So we're going to engage in some practical exercises to apply best practice approaches for responding to FEP and mobile crisis scenarios. We're going to understand linkage to ongoing care, incorporate cultural competence and cultural humility. We're going to build effective communication and rapport with individuals in crisis. So we're going to really enhance those de-escalation and communication techniques when we're working with individuals and families experiencing psychosis. We're going to collaborate and we're going to reflect. And so we're going to participate in some reflective discussions to process real world scenarios and receive feedback from peers, facilitators, and individuals with lived experience. And so this is our opportunity to really take the practical application of everything we've learned and put it into practice, something we love doing. And we have an opportunity to just really kind of hone in on that listening as that intervention. So very excited for the next training to come up. So we have the community of practice that is attached to this training, which will take place this Thursday. Training number 4, which is the final training for this series, which will be next month. And then as we wrap up today, I just want to thank you all for being here and for the work that you do in the community. It is life-saving and life-changing, and we appreciate and value each and every one of you. We could not do the work that we do in the communities without you. And so thank you. And just want to again highlight that everyone's experience is unique, and the most important thing we can do is listen. And that's why we always say that listening is an intervention. And so now we're going to open up for discussion. If you have any questions or if anything you want to share, any wonders, we're here. Also, thank you, Dr. Pierce and Dr. Hayden Lewis, for a wonderful presentation. Really appreciate it.
Hi, my question is, do you have any kind of a number of minutes or hour range? Are your teams that you're talking about limited on how much time they can spend with the people they're responding to, the household they're responding to?
Great question. And I just want to kind of reiterate that we have teams, mobile crisis teams across the state of California that are operating under the 58 counties. And so there are essentially 58 different mobile crisis teams in the state of California, and every team operates differently, but there realistically and ideally should not be a time limit. So meaning you should not say, well, you've got 60 minutes, your time started, you're at 2 minutes, we've got 58 minutes to go with you. That is not the purpose of this service. And so we're really out there to provide intervention and relief and support, and that is hard to do if you're working on a time clock.
Thank you. That was what I thought the answer was going to be, but different. I'm in Sacramento County, so our county, we're fortunate that our teams are open-ended. We're still having hiring issues, so sometimes maybe we leave, our teams are maybe leaving a little too quickly, is what we hear on I'm on our advisory board. Our community stood up an advisory board, so we have ability to learn as our program is going along, which things are going to work better for Sacramento County. And that was one of the big comments, was so nice to have the open-endedness. Previous to this, all we had was a few mobile crisis teams connected to our law enforcement, and those could stay a little longer, but it was not near as successful. So, and we're working on collaborating in case there's a need for a warm handoff, although in our area, our sheriff's department has decided they will not respond to anything, not even if there's a safety issue when our CRT teams get in the home or at the location. It's not always a home. Sometimes it's a park. Sometimes it's other kinds of living situations. So so we have a big challenge on our end, and we're having collaborate differently with our fire departments. That's all I wanted to say. Thank you.
Thank you. And Dr. Hayden Lewis, I see your hand up.
Yeah, I appreciate that question. It made me reflect on the usefulness of remembering that young people and their families, when there's psychosis involved, are going to have different tolerances for interactions and lengths of time. And so you may, when you're in your encounters, want to be gauging for that. And allowing to speak to the people that, allowing people to come and go, which you might already do from the conversation, allowing people choice to listen in and be present, take breaks, because of the symptoms and the demand on attention for everyone. It's really important to stay flexible with the amount of time, as well as what if I went away and took a walk around the block and just got out of your space and then came back, which isn't all about conflict. It's about processing and capacity in the moment. So I think that could be really useful for this group of folks as well.
Yeah, thank you. And then I see that we have the Sacramento CWRT teams will come the next day and future days to work on smaller steps. That's awesome. That's really awesome. Anyone else want to share kind of what their practices around response and time? We have a lot of different counties here in the room, so it'd be great to hear. Erin, I know you're in the room. Do you mind sharing a little bit about your experiences?
Yeah, I think just having the opportunity to go out and support people, kind of commenting off of their previous person, where it really is important to spend as much time as we can with the individual. We don't want to rush through things, and being able to meet with a family, meet with the individual, and be able to really connect and get them linked up to that next level of treatment, next level of service. So like a lot of times our goal with crisis services is really to not have to see that person again after we're done dealing with a crisis. So we can really link them up to the needed resources. And so they're not having to go back into that crisis situation. So, working with this team has been amazing. And, being able to make sure that people are comfortable, confident, and we're linking them to the appropriate services based on what their needs are, where their values are, and including them in all of that treatment planning. They are the experts in their own situation. And so being able to follow their lead is really important.
Thank you so much, Erin. Just scanning the room. I don't see anything. I don't see anything in the chat. A couple of people kind of also in regards to the response time and co-response and challenges there, increased liability. Yeah. Thank you everyone for sharing. And again, I just want to thank you all for being here with us today. It was great to see you all. I wish you all a great rest of your day and week. And thank you for joining us today. Have a great one.
Thanks, everyone. Take good care of yourselves.